This video will cover the definition, etiology, pathophysiology, and clinical features of tetanus. We will also discuss risk factors, evaluation, diagnosis, treatment, and complications. We are beginning with a general overview of tetanus. Tetanus is an infection characterized by muscle spasms and lockjaw, or trismus. It is caused by a powerful neurotoxin produced by Clostridium tetani, leading to painful spasms, particularly in the jaw and neck. The disease mainly affects unvaccinated individuals or elderly patients with decreased immunity. Tetanus spasms may last from minutes to weeks, starting in the face and moving down the body. Types include generalized, neonatal, localized, and cerebral tetanus. Tetanus is caused by the bacterium Clostridium tetani, found in soil, dust, or animal feces. It is a gram-positive, spore-forming bacteria that enters the body through wounds, lacerations, skin breaks, or contaminated objects. Risk factors for neonatal tetanus include an unvaccinated mother, septic cutting of the umbilical cord, and applying infectious substances like animal dung to the stump. Other general risk factors are burns, animal bites, war wounds, and unsterile surgeries. Clostridium tetani secretes Tetanospasmin, a neurotoxin responsible for clinical symptoms, and tetanolysin, a hemolytic toxin. Spores enter a wound, germinate under anaerobic conditions, and release Tetanospasmin into the bloodstream. The toxin enters the presynaptic terminals of motor neurons, inactivating inhibitory neurotransmission that normally suppresses muscle activity. This leads to the paralysis of muscle fibers. The toxin travels via retrograde axonal transport to the central nervous system, where it inhibits neurotransmitter release approximately 2 to 14 days after inoculation. This failure to inhibit the motor reflex causes tetanic spasms, which can be powerful enough to cause bone fractures and muscle tears. Once the neurotoxin enters the brainstem, autonomic dysfunction occurs, typically in the second week. Patients may experience unstable blood pressure and heart rate, sweating, bradyarrhythmias, and cardiac arrest. Symptoms can last for weeks to months. Clinical signs include lockjaw, a grimace facial expression called rhisis sardonicus, severe generalized muscle spasms, drooling, uncontrolled urination and defecation, and back-arching spasms called opisthetonus, which may cause respiratory distress. Diagnosis involves wound culture and isolation of the organism, along with a history of injury. The spatula test, which elicits an involuntary jaw contraction instead of a gag reflex when touching the posterior pharyngeal wall, also suggests a positive diagnosis. Treatment includes early wound debridement, supportive management, antibiotic therapy, and early administration of human tetanus immunoglobulin, or HTIG. Neuromuscular blockade and managing complications are also key. HTIG is the first-line treatment, removing released Tetanospasmin toxin, but it does not affect the toxin already bound to the central nervous system. A dose of 500 units is given intramuscularly or intravenously. Metronidazole has been shown to slow disease progression. Other treatments include penicillin and antispasmodics like benzodiazepines and baclofen. Intrathecal baclofen is effective for muscle rigidity. Mechanical ventilation and tracheostomy may also be necessary, especially if intubation is required for more than 10 days. These references were used to create this video. We have reached the end of the video. Thank you for watching.